See what we can get through. This honestly it's a fairly basic presentation because we covered some of the GU. Say what? Well, I want to get through at least 20 minutes here, and then I can record the rest. So when it comes to gyne procedures, oftentimes a lot of these are done under MAC or LMA. Like with the cervical localization, this may be done, you may see it boarded as like a LEAP or a DNC with a LEAP. A lot of times it's where someone has had dysplasic cells and they're going to go in and either have bleeding cauterized. There's always the risk of hemorrhage. Anytime you have a GYN case like a DNC, oftentimes people are grabbing Metrogen or Hemabate. Having some Pitocin around is always good. Certainly these are painful procedures, so make sure to adequately treat for pain. If you don't, you're more than likely going to have a vasovagal response. Patients have gone asystolic and gotten incredibly bradycardic. So make sure you're adequately anesthetizing them. I will say this, by far and large, I think macking procedures like this can be very difficult and potentially very dangerous, because having somebody in lithotomy not adequately anesthetized, or everything is going fine and then some increased stimulation, and very quickly will they cough, buck, move, aspirate, vomit. Be very careful. The majority of these patients are fairly healthy. You have to consider if they have anxiety, make sure to treat for that. If you want to do ERAS, you can give them Tylenol, Toradol, magnesium. Some people, I know gabapentin's listed. I think a lot of people are getting away from the gabapentin. I think when you see Jaffe updated next, you're going to see that moving away some. General anesthesia, you can do regional, whether it's a spinal or, I mean, you could potentially do an epidural or a CSE, but that would only be if it was going to go for an extended period of time. If you are doing general, I highly recommend Ativa. I think, women, non-smokers are going to be higher risk for PONV. Complications for positioning, pay close attention to how they position the legs. Make sure that patient is adequately secured on the bed, especially if you're going to be in seat Trendelenburg. And if the patient starts to move, speak up. Don't sit there and wait. It's better to move the patient sooner rather than later. When it comes to hysterectomies, multiple approaches. It's one of the most frequently performed surgeries in the U.S. You're going to see more than likely robotic, more than anything, robotic and laparoscopic. These can lead to a prolonged surgical time. Prolonged time spent in the lithotomy position has a number of risks. The big thing, if it's an abdominal hysterectomy and the cervix is removed, it can be spared in a supracervical approach. Make sure if you are going to do these cases open that you consider some form of regional anesthesia, either TAPS or QLs, and then make sure that these patients are, if depending on your surgeon, at least type in screened. Occasionally they'll know if they're going to get into bleeding and they'll tell you, hey, we need to go ahead and cross match the patient, but I would not routinely cross match. So when it comes to hysterectomies, oftentimes, especially if you're at a teaching facility, you're going to have students coming in, whether it's medical students, residents, and this has come under fire lately for multiple people performing exams while someone is under anesthesia. That is something that hopefully if you're at a teaching facility that is consented for, but if patients ask, make sure to refer them back to the OBGYN or the surgeon, because I think from our perspective, if people have not introduced themselves to the patient or they're letting 4 or 5 med students do an exam, even at a teaching facility, that's not appropriate. I would make sure to speak up if you're ever in a situation like that and you're uncomfortable, and at least make it known. You can do spinal, you can do regional. I would say the majority of these are going to be general. One thing you're going to see talked about in Jaffe, and depending on where you go in practice, for a good long while, especially before blocks, people would do intrathecal morphine, all right, and then do general anesthesia. So they would sit you up, do a spinal, inject Duramorph, like 0.25, all right, and then put you to sleep. So the Duramorph helps with the post-op pain. because some of these patients stay the night. Okay, if they get dermorph, they have to stay the night. They need to be monitored 24 hours post-op. However, a lot of places are getting away from that. I think that's truthfully terrible. These should be outpatient cases. All right. So if you're ever asked for that, or maybe it's an older surgeon says, "Oh, we're not going to give them dermorph," and you're thinking, "What on earth are they talking about?" That's what they're referring to. Is this patient staying the night? Should be the first thing you ask, and then if you do that, if hey, that's the culture where you go, they have to have pulse oximetry on. They have to. Do not send them to an unmonitored floor. All right. For hysterectomies, number of pre-op diagnoses, whether it's gynecologic cancers, uterine masses, pelvic organ prolapse is also up there, uncontrolled uterine bleeding or dysmenorrhea. You should consider the pre-op diagnosis. For your anesthesia considerations, respiratory-wise, certainly your positioning is going to matter the most. Sometimes they will have these patients do a bowel prep, and I will say the newer bowel preps, you have less electrolyte abnormalities, less true intravascular dehydration. I would say, like I said, type and screen unless you are pretty sure you're going to get into bleeding. Minimal preoperative testing is needed. If you're going to do ERAS, consider not only a block but PO medications as well. Intraoperatively, if you're going to do a spinal, of course, if you're doing this open, you can do it with a spinal. If you're going to do intrathecal morphine and then put them to sleep, like I said, I don't recommend that. However, some places have done that for years. Has anybody seen that or anybody heard about that? It's a very old school thing, but it'll occasionally get brought up. I do think for these cases, a TIVA is more than ideal. If you want to do regional, it's going to be open, and the surgeon says, well, this could take a long while, and the patient really does not want to go to sleep, do a CSE, and this way you can use that epidural catheter to augment that block whenever you need it. So combine spinal epidural, put your spinal in, and then as that spinal block wears off, you can give something epidural. This way you can make it last however long it needs to. When it comes to IV access, at least one good IV. If you need to give blood, consider that. You should have access to the arms. So if your patient is a difficult stick or anything like that, you can get a 20 gauge, go back there, go to sleep, and then you can throw one in whenever they're prepping. Oftentimes they're going to do position the patient in the lithotomy. They're going to ask for legs down, or they may take off part of the bed, or they may ask you to put the foot all the way down on the bed. Wash the patient's hands. Whenever you guys are out on your own, you can do whatever you want. You're going to work with a lot of CRNAs that have the patient move down in the bed before positioning or before you go to sleep. All right. The textbook answer is the patient should be at the head of the bed. You should secure the airway before you move the patient. Whatever you do whenever you're out, completely up to you. All right. Same thing with hysterectomies. When it comes to postoperative complications, PONV is going to be a big one. Bleeding, consider regional. As far as DNCs go, a lot of people will try to do these MAC. I'll be very honest, doing an LMA with a little bit of rocks that don't cough or move is much easier, because if you're trying to keep them still without any paralytic, and you'll go in spurts where nothing is very stimulating and the patient is hypotensive or maybe not breathing, and then suddenly they have a change in stimulation and that patient's coughing and moving. So also, if somebody's in the lithotomy position, all right, and they're too light, all right, you can have nerve injuries, you can have a lot of issues with that. Please pay very close attention to these patients. Elderly people, all right, for DNCs, put them to sleep and paralyze them. You can get by with giving them much less, because it's a lot easier to anesthetize someone, all right, and keep them relaxed with paralytic and give them a minimal amount of anesthetic than trying to keep them still with propofol or fentanyl. For DNCs, they're going to perform an exam, insert a speculum, probe, the cavity will be dilated. It is painful, sometimes with polyps. And some of these cases can be really quick, 5 minutes. Some of these cases take a good long while. You should know where there is methogen or hemabate along with Pitocin, having that available. Usual pre-op diagnosis is somewhere between abnormal uterine bleeding, incomplete or missed abortion, cervical stenosis, or dysmenorrhea. Those are all very common. Just a brief bit about the therapeutic abortion or dilation and evacuation. If you're ever in a situation where you have to do these, you can do these MAC, you can do these general, but I would say the majority of these patients are going to be incredibly anxious, and if you're in a situation like that, consider somebody's anxiety and make sure you have good IV access. Sometimes you can have uncontrolled bleeding. Like I said, often healthy patients, bleeding and sepsis can be your big complications. Now, big on the TIVA, so think about, consider who's going to be high risk. If you have somebody who potentially has a history of, maybe they've had a number of blocks, or maybe they've had some failed spinals or epidurals, weigh your pros and cons of attempting, a regional anesthetic or doing a spinal. If somebody tells you, hey, they had a hard time getting my epidural last time, I have scoliosis, it may not be worth trying to do that. Certainly involve your patient in that decision, but that's entirely up to them. As far as intraoperatively, like I said, bleeding is going to be the big thing. If you do have that patient awake, all right, they may get nauseous, treat that blood pressure, and then consider that positioning as well. That's going to be huge for these cases. And then anesthetic considerations, same thing as we've discussed. If you're going to do NSAIDs or anything like that, make sure you talk to the surgeon if they're okay with it. If there has been bleeding, I will say sometimes OBs will ask for Toradol IV and IM. That is not effective. That's not recommended. So OBs love Toradol whenever there's not abrupt bleeding. Hysteroscopy, so very similar to a uteroscopy, except this is a hysteroscope. So abnormal uterine bleeding, infertility evaluation, whether there's polyps, fibroids, adhesions, all the same principles. Keep this patient still. Don't let them cough or move. It can be very challenging to do this without putting the patient under general anesthesia. At times, you may be asked to go and do office-based sedation. That was one thing that we would do is hysteroscopies in the office, and we would do that with sedation. Typically, it was a Versed fentanyl, and then just enough propofol to keep them still. But as you can imagine, sometimes these patients require a lot more, and sometimes patients, you're going to need to mask them or help breathe for them because they're so sensitive to narcotics. If they happen to mention, oh, hey, we're not getting fluid back, immediately start looking at that abdomen and assessing. Perforations have happened, and if they're not getting fluid back, this can lead to electrolyte abnormalities and can lead to some big problems, okay? Just like with TERP syndrome, very similar, you can have those abrupt electrolyte derangements. And normally this is abnormal uterine bleeding, infertility, something along those lines. So with the hysteroscopies, consider the patient's medical history. Make sure that if they are anxious, they are, needing a lot of anxiolysis, give them something ahead of time. It doesn't have to be a benzo. It can be dexmedetomidine. All right, that's going to help reduce that anxiety, give you a little smoother induction. Consider your NSAIDs as well. If there's a lot of bleeding, you may want to skip it or do a lower dose. What dose of Toradol are you guys seeing? 10, 15, 30?
15 or 30.
Yeah. All right. So consider your dose of Toradol. If for some reason you're worried about maybe aspiration or GERD, consider Pepsid as well ahead of time. You can do hysteroscopies, like I said, with MAC. Sometimes in the office they may do a paracervical block or a pudendal block. I would say the majority of people are not going to want that. If that's offered in office, a lot of people are going to refuse. We have people coming to the OR to have IUDs placed and removed due to anxiety. So I would say in-office hysteroscopies are going to be performed less and less. If you have a patient that has that is scheduled for that and they want to do it MAC, like I said, make sure and consider how deep you need them. If you're going to do regional, you need about a T10 level. All right, so whatever level you need, I would say at least go, 2 to 4 levels higher if you're like urologic or gyne, to make sure you have good coverage, but not exceeding a C-section dose. You don't want to go any higher than T4. All right, so if these patients, if you're wanting a T10 level, dose that spinal appropriately, you can give a C-section dose and then leave them sitting up for a good period of time. And then if you do add anything to it to densen that block, it's going to extend that time that your spinal is going to last. As far as hysteroscopies go, same principles as all the other GYN procedures, very similar. Make sure to watch them for cramping or bleeding. If they have had bleeding, consider whether or not you want to do NSAIDs. Hyponatremia can occur, and if they start having symptoms of it, all right, you want to very quickly check an electrolyte panel. There's a lot of surgical operations for stress urinary incontinence. So the urogyn physicians, so specialized urologists or OBGYNs who've done an additional fellowship that really focus on a lot of these procedures. Talk to them, find out exactly what they need, how long it will take. And this is another one where I would say I got bamboozled one time. I had a student, hey, I just need a little bit of sedation, it's not much, not super stimulating. I had to emergently intubate that patient because couldn't sit still. The OB's getting frustrated because the patient's moving. You said you didn't need much sedation. What do you want? So be very cautious. Ask other people if it's the first time you're working with a surgeon. By all means, you can take the recommendation, but at the first sign of trouble, just put them to sleep. Don't wait until you're desaturating or anything like that. All right. As far as approaches for these, they can be a million different ways they can do this. By no means are you going to be a specialist in this. I just want you to know, can I do this with sedation? If I do this with spinal, I need about a T10 level at least, or you can put them to sleep. If it's going to be an extended period of time, that's probably the best thing to do. Additionally, consider positioning as well. Lithotomy, that's where people are going to get burned. You don't want to get out and have a nerve injury in the first, you don't want to have it at all, but especially as a new CRNA, you need to be hyper vigilant over those easy to miss things. All right, same thing here. These are more looking at the type of procedures. All right, they can do this, like I said, a bunch of different ways, but the positioning is going to be huge. If there's an abdominal incision made, you're going to need at least a T4 level, T10 if it's purely vaginal, and you should consider to monitor for complications. If they have any doubt, a lot of times they're going to do a cysto intraoperatively, or if there's an obstruction, and sometimes these procedures, hey, this is going to be 20 minutes, and this turns into a 4-hour case. And in those situations, if you've done regional or if you are macking them, just put them to sleep. So many good principles are around the fact of, hey, I'm going to keep the patient safe. All right, safety requires them not moving, not coughing, not aspirating. So, same thing for pre-op diagnosis, stress urinary incontinence. This can be post-childbirth, or this could be somebody who maybe has had, just changes with aging as well. Maybe they've had catheterization that they've needed. So normally these are outpatient, so you don't need to go. If they are elderly, I'd be very careful with Versed or anything like that. You don't need to give anything too strong if it's going to be outpatient. Can do it, same thing like we've talked about. If it's abdominal, T4 level with the spinal. If it's just vaginal, about a T10 level. And post-op nausea and vomiting, that should be a consideration. Elderly people are less likely to have it, although I do think a TIVA is probably a little cleaner anesthetic for your elderly patients. For tubal ligations, all right, elective, voluntary, these are considered permanent. Make sure your patient understands, make sure that the surgeon has talked to them, and make sure that things are documented appropriately. If somebody wants a tubal ligation and they do not have children and they request one, the surgeon needs to do it. There's been a lot of issues with that, about surgeons gaslighting patients into, oh, you don't want to do that, or maybe you'll change your mind. And these patients, there have been lawsuits over that, or forcing somebody to take a pregnancy test. Patients can always refuse. So just be aware of things like that. That will come up on occasion. Normally, your pre-op diagnosis is desire for permanent sterilization. Sometimes you can do a tubal with a C-section, so hey, they're already in there, but that form, that consent has to be signed prior. It's not one of those, oh, hey, doc, while you're there, go ahead and tie my tubes. It's not like that. Anesthetic planning depends heavily on timing. If you can do it post-delivery, if it's already planned, you can keep the epidural catheter in place. However, okay, if it's 12 to 24 hours afterwards, now that epidural has been in, probably 48 hours, has that patient wiggled and moved? Is that catheter really in place? Oftentimes, if that coverage is not there, you probably should just put them to sleep. I will say consider these patients at risk for gastric aspiration, especially if it's the closer it is to delivery. Now, you could get really fancy and do gastric ultrasound if you wanted to, but I would err on the side of caution, especially for a new mother. You don't want to be taking risks. If you're going to do it with a spinal, once again, no sedation, T4 level, but if it's laparoscopic or anything like that, of course, you're going to put them to sleep. Monitor for hemodynamic changes, especially in laparoscopy. If your gut is ever telling you, hey, I might need to give this patient glyco, go ahead and do it. Don't wait until they have a vagal response. That bradycardia can be life-threatening. And if you do have sustained and severe bradycardia, go atropine quicker, and then if not, immediately break out the epi. It doesn't take a ton of epi. Don't give a whole milligram. I mean, certainly if you need to, give an ACLS dose, but normally, somewhere between 25 and 100 mics is more than enough. For your anesthetic considerations, if you're going to use anything oral preoperatively, don't immediately go in and put an OG tube in and decompress their stomach. What's the point in that? I see that happen a lot if somebody has been pre-medicated, or a lot of times with our ortho cases. Consider their risk for post-op nausea and vomiting, and sometimes these patients are going to be pretty uncomfortable afterwards. So if the OB has not, or the surgeon has not injected local in the port sites, I typically always ask for that for most, honestly, laparoscopic cases. So, and really this transitions to the perineal procedures like perineoplasty, repair of obstetrical lacerations or episiotomies. Sometimes those are incredibly intense, and you may take a patient from literally OB directly to the OR. And in those situations, if you can dose up the epidural catheter and keep them awake, great. If not, put them to sleep. All right. A lot of pain, a lot of discomfort. If you have somebody that, hey, we're going to do it 24 to 48 hours afterwards, you can do a spinal as well, get a good dense saddle block. But the majority of the time, all right, if it's during childbirth, you're going to fix it sooner rather than later. All right. These patients typically are in a decent amount of postoperative pain. Make sure you treat them appropriately. Give them good education on whether or not they can continue breastfeeding. If they're awake enough to hold their baby, all right, more than likely they're fine to breastfeed. They don't need to pump and dump. The one big drug to potentially avoid is probably going to be meperidine. All right. For the pelvic floor reconstruction procedures, very similar to the urologic reconstruction procedures. Ask your surgeon what they need. Most of these are going to be general. All right. T-Berg positioning, lithotomy. Pneumoperitoneum risks as well. Keep in mind that possibility for significant surgical time and blood loss. Review this slide. Know the lithotomy and Trendelenburg positioning risks. This is hit heavy on boards and heavy on the C exam. You have a number of options for regional anesthesia, pelvic nerve blocks. Be familiar with what a pudendal block is, how you would place a saddle block, how much local anesthetic you would use, and what type of block that will give you. And then, of course, consider postoperative pain control. It shouldn't simply be just more opioids. If you can have some form of regional, if you can make sure that you're giving your NSAIDs, make sure that you're optimizing those patients. You want them to have good early mobilization. You want them up. If this is something that can be done outpatient, you want them to go home. You want them to have as minimal side effects as possible. These are all probably cases many of you have done. They all have very similar shared principles. The big thing is, if you're going in for one of these OB cases and you think you need Methergin or Hemabate, have it with you, have Pitocin with you. Don't wait until it becomes an emergency. If your gut tells you, hey, I should send a type and screen, go ahead and send it. And if they have an unusual amount of postoperative discomfort, very quickly notify the OB and have them come over and do an ultrasound. Whether it's abdominal bleeding, or maybe they've had a perf and they didn't notice it right away. I've had a number of those where we've had to go immediately back to the OR and open somebody up. So excessive amounts of pain, things aren't making sense, very quickly grab your ultrasound. You can throw a probe on the stomach and you can see if there's fluid in there or anything like that. But the OBs are going to be, they're going to want to take a look at it. Certainly don't say, okay, we're going back to the OR right now. So let them make that call.